This is a general disclaimer. Redlands Community College attempts to have the most accurate and up-to-date information listed in its content and delivery. However, your education is your responsibility. Redlands Community College or Roy Smith makes no guarantee in the accuracy of this information in this video and accepts no liability for the informational video. The information expressed is strictly the opinion of the author and the presenter, which is listed in the reference near the end of the video. This information is designed to supplement your own education or initial education and should not be used to replace any current academic program you're enrolled in. View the information and content at your own risk. Thank you. This is going to be Chapter 11, Metabolic Emergencies. And quick introduction to this. This chapter presents medications that are used to treat metabolic diseases such as diabetes. Two classes of emergencies are associated with diabetes, one being hypoglycemia, which is insufficient sugar for cellular metabolism, dire risk to brain cells because the brains require sugar, easily corrected but difficult to keep in balance, especially if they're fragile. Diabetic ketoacidosis, insufficient insulin or insulin resistance in the body. Ketone production when fats are used to produce the energy. And that would be there's no insulin to allow the sugar in there for energy, so the body taps into the fat sources. And high blood sugars are characteristic in this. So diabetes, we have two types. A type 1 diabetic, this presents at a very early age with acute onset. They're at a risk for ketoacidosis because of their lack of insulin. So we get ketoacidosis as a result of inadequate insulin, not having the ability to get sugar into the cells, and tapping into fat supplies required for the administration of insulin for the remainder of their lives. Type 2 diabetes is caused by a tissue resistance to insulin, impaired insulin secretion, and increased hepatic glucose production. Normally develops in individuals that are at least 40 years of age and has more of a gradual onset than type 1. Obesity is generally a factor associated with type 2. Treatment of type 2 diabetes mellitus may involve just diet, exercise, or exercise oral meds, or all three. Some patients do require insulin administration with this as well. So type 1 diabetics, very simply, they have a diminished amount of insulin. So what that does is there's not enough insulin to allow the sugar across the cell, so we get an increase in the amount of insulin that is extracellular. And this essentially diminishes the amount of glucose uptake into the cells and reduces the amount of energy. So what the body can do is, if there's tons of glucose out here and there's not enough insulin, the body will tap into fat stores, and this is what gives us our environment set up for diabetic ketoacidosis. In the type 2 diabetic, the body makes absolute enough insulin. The problem is that the insulin receptors on the cells are resistant. They really don't like the insulin that the body produces. So what that does is an alteration of the same thing. It makes glucose levels high because the body is resistant to the insulin. So hyperglycemia, high blood glucose. Diabetic ketoacidosis occurs when the glucose becomes too high. That's because in diabetic ketoacidosis, the body taps into fat supplies and starts utilizing them. Byproducts of this are ketones. May occur because of insulin doses too small or not administered at all, or the amount of carbohydrates taken is too large. May also occur because of physical or emotional stress, such as an infection. Now, stress hormones and things like that alter our way that we provide sugar metabolism. So very simply, a fragile diabetic cannot take a lot of stress, and it'll get the sugars completely out of whack. Hypoglycemia occurs as a result of too much insulin and too little food. There is a balancing act between the two, food and insulin. There has to be a balancing act. So if you take your insulin and don't take in enough ingestion of food, this is going to be out of kilter. You're going to have too much insulin for the amount of food, and very simply this will alter your level of consciousness because you have to have adequate amounts of sugar. The brain requires glucose for metabolism. Lack of glucose reduces brain metabolism and causes neurological and psychiatric symptoms. Hypoglycemia may develop very rapidly. treatment, fingerstick blood sugar of less than 80 gets dextrose 50%. Now the dosing on that is going to be, the book will say 10 to 25. Most of the time it's easier for us to figure and give them 12.5 to 25 grams. That's a whole amp or a half of an amp, essentially. Antidiabetic. We're going to talk about 3 medications here: insulin, glyphosate, and metformin. Alright, this is going to be insulin, and the generic on this is going to be insulin regular. Trade name on this is going to be Humulin R or Novolin R. Mechanism of action, and this is the actual insulin hormone that allows the sugar in the cell. Insulin is a protein secreted by the beta cells and the islets of Langerhans. This is in the pancreas. Insulin is responsible for promoting the uptake of glucose by the cells. When administered, it is distributed through the body. It combines with insulin receptors present on the cell membranes. This promotes glucose entry into the cell, and this is done through facilitated diffusion. In diabetics, when insulin secretion is diminished, supplemental insulin must be obtained by injection. Older forms of insulin are derived from animals. This will be bovine for bulls and porcine for pigs. However, animal insulin is not identical to human insulin. Because of this, many patients will develop antibodies to animal insulin, rendering it less effective. Human insulin can be manufactured through genetic engineering, recombinant DNA technology. Genetically engineered insulin, Humulin and Novolin, is chemically identical to the insulin hormone secreted by the pancreas. Patients do not develop antibodies to the human insulin as they do animal insulin. And the adult dose in this for ketoacidosis is 0.1 unit per kilogram per hour, and then maintenance therapy after that of 0.5 to 1 kilogram per day. In hyperkalemia, dextrose should be administered 0.5 to 1 gram per kilogram combined with 1 unit for every 4 to 5 grams of dextrose given. In the pediatric dosing, ketoacidosis is 0.1 unit per kilogram, followed by a continuous dose of 0.05 to 0.2 units per kilogram per hour. Maintenance therapy of 0.5 to 1 unit per kilogram per day. In hyperkalemia in the pediatric, dextrose of 0.5 to 1 gram per kilogram combined with 1 unit for every 45 grams of dextrose. Contraindications: certain individuals are hypersensitive to beef and pork insulins. Do not administer insulin products derived from these sources to these patients. Other animal-derived insulins to which the patient is not hypersensitive or biosynthetic insulin should be used in these cases. Pharmacokinetics on set is going to be 0.5 to 1 hour, duration 5 to 7, and elimination less than 2% in the urine. This is generally going to be through cellular byproducts and cellular metabolism that this is going to be eliminated or used up. Glyphosate or metformin, this is general knowledge, but you're going to see a bunch of your type 2 diabetics on this. And essentially what we have here, I want you to understand, is the mechanism of action. So for the type 2 diabetic, please remember they are insulin resistant. Decreased hepatic glucose production decreases GI glucose absorption. So from your diet, it decreases the amount of carbs or glucose that you're actually absorbing. Increase at target cell insulin sensitivity. So the insulin cells, so the cells and the insulin receptor that were sensitive, it decreases that sensitivity. So it says, please pay attention to the insulin that we're putting on board. So this is very helpful for the type 2. Antihypoglycemic agents. We have 2 of them, one of them being dextrose and the other one being glucagon. Dextrose 50% in water. Generic on this is going to be D50, and the trade name is going to be D50, same and same. Mechanism of action: dextrose 50% in water increases circulating blood glucose levels to normal. Also acts as briefly as an osmotic diuretic, and that's because of very large molecules. The molecule on a sugar molecule is C6H12O6. A very large molecule, has a lot of molecular weight to it, and unfortunately will pull fluid towards it. Adult dose on this is 10 to 25 grams of dextrose 50% in water, and this is what I was talking about earlier, that we generally just give 12.5 to 25. That's a half or a whole of the dextrose 50%. Pediatric dosing, pediatric greater than 2 years, 2 milliliters per kilogram. And this is milliliters, not milligrams, per kilogram of dextrose 50%. Pediatric less than 2 years, 2 to 4 milliliters per kilogram of dextrose 10% in water. So please pay attention to these. It's still dextrose, but this is more dilute. So this is a 10% solution of dextrose in water, and this is a 50% solution of dextrose in water. The easiest way for us to make this, if we don't have it on hand, is to, I'll give you an example here. This is dextrose 50% in water. That means that there's 25 grams in 50 mils. So if we squirted out half of this solution, we would have 12.5 grams. And then we sucked up essentially normal saline. And what that's going to do is that's going to now make it into 50 milliliters. So this was going to be 12.5 grams essentially in 50 mils is our new concentration. So we squirt out half of the substance, or the half of the dextrose 50, stab the bag, pull up half again, and re-dilute it. That's generally what we do to individuals that are 2 to 4 milliliters, and then we give them 1 to 2 milliliters per kilogram. We'll talk about this again in PALS. Contraindications: do not administer D50 to patients with intracranial hemorrhage. It will cause a shift in their head. Very simply, it could increase bleeding again. Very dangerous. Untoward effects will occur. Pharmacokinetics onset less than a minute, duration dependent on the degree of hypoglycemia. Metabolized to carbon dioxide and water. Glucagon, this is also primary care. Generic on this is going to be glucagon, so is the trade. Glucagon is in the pancreas. We essentially have 3 cells. We have alpha, beta, and delta cells. Alpha cells secrete glucagon, beta cells secrete insulin, and delta cells secrete somatostatin. So this is what we're giving these patients whenever we give them glucagon. Glucagon is a natural polypeptide hormone produced by alpha cells in the islets of Langerhans in the pancreas. When released, it causes a breakdown of stored glycogen to glucose and inhibits the synthesis of glycogen from glucose. So it kind of stops it from the body from storing it and says, hey, let's make some active glucose. Both actions increase blood glucose levels given via intramuscular route. It is a useful drug in hypoglycemia when IV access is unsuccessful. Glucagon also increases the heart rate and myocardial contractile force and improves AV conduction in a manner similar to that produced by catecholamines. Its actions are independent of the beta blockade. So we also use this for beta blocker overdose as well. Adult dosing on this for hypoglycemia would be 1 milligram intramuscular or subcutaneous, or IV every 20 minutes for a total of 2 milligrams total, and beta blocker overdose 2 to 5 milligrams IV over 1 minute. Please check your local protocols. Pediatric dosing less than 20 kilograms or 40 pounder, 0.5 milligrams. That's supposed to be IM, IV, or sub-Q. And the beta blocker overdose, less than 20 kilograms, we would have 0.5 milligrams, IM, IV, or sub-Q. Contraindications: do not administer glucagon to patients who is hypersensitive to the drug. Pharmacokinetics: onset 5 to 20 minutes, duration 1 to 1.5 hours, metabolized in the liver, plasma, and kidneys, and eliminated in the urine. Beta adrenergic antagonists, and this is going to be Esmolol. This is going to be a general knowledge drug. Generic on this is going to be Esmolol, or the trade name is going to be Brevibloc. Now, we give this to people to treat sinus tachycardia and supraventricular arrhythmias, essentially. This is a beta blocker, so it's going to block, more specifically, beta 1 and maybe beta 2. Now, what this does, Esmolol is an ultra-short acting. This is general knowledge, so this is what I want you to put in your brains. Esmolol is an ultra-short acting beta-1 adrenergic blocking agent with cardioselective properties, but devoid of intrinsic sympathetic activity or membrane stabilizing quinidine-like effect activity. Its hemodynamic effects are mild, with potency as a beta blocker about 1/100th of that of propranolol. So very low entry level, low potency beta blocker. That's what this is. We use it for tachycardias and supraventricular arrhythmias. Corticosteroids, hydrocortisone. A corticosteroid essentially does a numerous amount of things in there in your body. Corticosteroids essentially depress the immune system, and they send some cellular signaling that increases certain muscles to catecholamines. Now what that means is, and we're talking about this area over here, that it would increase beta-2 receptors. And what that means is it makes the cellular environment more sensitive to things like adrenaline and albuterol. So very good drug of choice. This stuff is used in multiple facets. Now, in asthma, more specifically, and in catecholamine-resistant septicemias, what we see is we see a cellular-mediated response, and that causes inflammation. If we've had the patient on several different types of vasopressors, to be honest, this is the trick over here. Decreasing endothelial leakage and beta reception, and the decrease in cellular-mediated activity is kind of what I would want to see giving it. In asthma patients, I would want to see less inflammation, and if the patient had used a bunch of their own albuterol, I would like to see an increase in the amount of beta receptors so that the cellular material would pay attention to what I'm asking it to do, which is dilate. So those are all the things that corticosteroids give us. They resemble something called glucocorticoids that we secrete in the actual adrenaline glands. So our body and the adrenaline glands secretes mineralocorticoids and glucocorticoids, aldosterone primarily, and then something that's very similar to hydrocortisone. So primary care drug, generic on this is going to be hydrocortisone. The trade name is going to be Solu-Cortef. Mechanism of action, hydrocortisone is a short-acting synthetic steroid with both glucocorticoid and mineralocorticoid properties that affect nearly all systems of the body by inhibiting the formation, storage, and release of histamine and mast cells, so decrease in the cellular-mediated response and inflammation. It reduces the effect of the allergic response. It also increases the body's response to circulating catecholamines. Now that's important as well, especially if they're using a steroid to treat a pediatric patient that is already resistant to catecholamines or resistant to the vasopressors that they might have them on. Adult dose in this is going to be 100 to 500 milligrams IV. Pediatric dose 1 to 2 milligrams per kilogram IV. Contraindications: active untreated infections, and this would be something to where we are risk versus benefit. Are we depressing the immune system enough to cause more damage? Patients with known alcohol or bisphenol hypersensitivity. And pharmacokinetics on this are going to be onset immediate, and the duration is going to be 1 to 1.5 days. And the byproducts on this are going to be excreted in the urine. Vitamins in this chapter are going to be thiamine. This is going to be thiamine. Generic on this is going to be thiamine, and the trade name is going to be Betadine. Primary care drug. Mechanism of action on this: thiamine is a water-soluble vitamin and a member of the B complex group. It functions as an essential coenzyme in carbohydrate metabolism. Thiamine is not produced by the body and must be obtained through the diet. It is required for conversion of pyruvic acid to acetyl coenzyme A. Without thiamine, a significant amount of energy available in glucose cannot be obtained. The brain particularly is extremely sensitive to thiamine deficiency. Chronic alcoholic intake interferes with the absorption, intake, and use of thiamine. Thus, a significant number of alcoholics have thiamine deficiencies. Two serious neurological conditions, Wernicke's syndrome and Korsakoff psychosis, can result from thiamine deficiencies. Altered mental status from alcoholic sources, or a patient with chronic alcoholism in their background, thiamine should be used. Adult dose on this: 100 milligrams of thiamine in 50 to 100 mils of normal saline. We're going to dilute it a little bit, or D5W. Rapid administration may cause actual hypotension whenever we administer it. And this should be administered probably over about a good 20 minutes. Nice and slow. Creep it in there. Dextrose D5 infusion over 15 to 20 minutes is what it advises, and this is from your book. Pediatric dosing is not recommended in the pre-hospital settings, and there's no contraindications when the above indications are given, and that would be Korsakoff's syndrome, altered mental status secondary to alcoholism or with alcoholism in their history, or with a thiamine deficiency is thought. Pharmacokinetics, metabolized in the liver and excreted in the urine. In conclusion, patients suffering from metabolic disorders can exhibit many different signs and symptoms. Treatment of the diabetic patient depends on accurately assessing the patient. Correct, timely treatments is vital. The patient found in a coma needs a rapid, accurate assessment. Drug treatment for these patients is diagnostic in nature as well as being potentially life-saving. References for this chapter were taken from Beck Pharmacology for MS Providers, pages 166 to 175, Del Mar Learning, and Brian Bledsoe, Pre-Hospital Emergency Pharmacology, 7th edition, Prentice Hall, and various images throughout the internet and the slides they're associated with. If you have any questions concerning this chapter, feel free to give me a call. My name is Roy Smith, smithr@imsa.net, or 405-219-7613. Thank you.